Hello, this is Sidney Foshi. I'm a captain in the Medical Service Corps in the United States Navy, and I would like to talk about state-of-the-art medical simulation facilities. Specifically, like to talk about the Val G. Heming Simulation Center, which is under the Uniformed Services University. I had the privilege of being able to conduct my practicum with this center, and I'd love to tell you all about it. In talking with Dr. Darkin about the idea for this tech talk, he wanted me to discuss, what in my mind is an ideal simulation center. And an ideal simulation center, it would have all the different types of simulation that you could want. It'd have part task trainers, it would have mannequins, it would have virtual reality, it would have a mix, really anything that you could desire. It'd have standardized patients. It'd be a large facility that would have a robust staff that's very innovative. The center would be well funded and, it'd be really considered state-of-the-art and cutting edge. Dr. Joseph Lapriato is the director for the Val G. Heming Simulation Center. He was a captain in the United States Navy, now he's retired, and he was there for his last tour and transitioned into the director role. I had a chance to interview him about the challenges of running the center, and it's a very large, complex operation. There are a lot of people. They have good funding levels, but they're not conjoined with the university. They're some distance away from the campus, and the center is also in two different buildings. So it's a question of managing the people, managing the money, and effectively utilizing the space to provide the best simulation experience that they can. The mission of the center is to deliver and develop leading-edge advances in medical simulation, education, research, and readiness. In order to do this, they've divided into three divisions. Clinical skills, learners can come in and they can develop their skill sets. For example, maybe first-year medical students would come in and they'd learn how to take a medical history. Second-year students could add physical exams to their repertoire. Third-year students would go on to more advanced specialty skills. They have a variety of mannequins and task trainers, from mannequins that have blast injuries and amputations to fully digitalized mannequins that are very expensive. They have the wide area virtual environment, which is 8,000 square foot of virtual space where they can actually display simulation in a hybrid approach. And we'll talk about the Wave more later. Now, a great simulation center is going to have all of the different types of simulation that you're going to need to be able to complete whatever your specific learning objective is for your students. And this center had everything that I could think of and more. It was just absolutely astounding, the capabilities that they had in their two different buildings. And we'll go through and talk about each of these in subsequent slides. During my practicum, I was able to observe the use of three different task trainers. One task trainer was a baby, and the student had to come in and provide ventilation with a hand squeeze bag, and they could monitor the oxygen levels of the baby on the monitor to see how things were going. There was a leg, not a whole simulator, not a whole mannequin, but just a leg. And the student had to practice inserting the needle into the bone. In a combat situation, you would insert the needle into the bone and you could quickly administer fluids if a person's life depended on it. And the third task trainer that I saw was a model of an ear. The student could come in and they could use their instrument to look inside the ear and they could see different images. And instructors could actually see the images on a laptop computer to see what the student was seeing. And the student was diagnosing what was wrong with the ear. For example, could they diagnose correctly that the patient had an ear infection? I saw a wide variety of mannequins at the center during my 2 days for the practicum. There were mannequins with torsos and heads that had injuries to simulate battlefield wounds, that the student would have to assess the situation and come up with a treatment plan. Although I'm not sure they're mannequins, there were cut suits where a role player or a standardized patient who's wearing the suit with the injuries, and the learner would have to come up, make a decision on the cut suit, insert tubes, and the standardized patient is sitting there moaning, screaming, crying, asking for help. There were mannequins that had, parts of legs to represent blast injuries and amputations. I saw very deluxe, expensive models of mannequins where they could actually have responses to questions. Now, again, this is not artificial intelligence. There was an instructor in another room that was providing the responses that were going through the mannequin, but it was still very impressive. They developed on-site tattoos that they could place on the mannequins to represent injuries, or they could actually paint, through some of their artists, paint injuries onto the mannequins, which they refer to as moulage. Standardized patients really impressed me at the facility. They hire people to come in and play roles, much like role players or actors. These people have to memorize their lines. They have to memorize their symptoms. And they are assessed and evaluated by other standardized patients who may be in the room at the time of the session or may be observing through monitors. The center has training sessions for their standardized patients to ensure the quality of their product. And these people, these standardized patients, are actually highly trained subject matter experts in physical exams. Some of them are paid, and they're all paid, but some of them actually come in and they do pelvic exams on the standardized patient, or they do rectal exams on the standardized patients. And in talking with the director, a lot of times these folks had bad experiences with these certain exams, and they didn't want anyone else to have an experience like they had, so they will come in and they will be a subject for a student's rectal examination. Now, the center spends over $400,000 a year on standardized patients, so it's a sizable investment, but it's just remarkable to observe, and you really forget that you're looking at an actor when you're watching these scenes unfold. The wide area virtual environment is really the crown jewel of the center. For virtual reality, I was presented with a scene perhaps out of Afghanistan. For the first central area, you could have a standardized patient playing a wounded soldier or sailor, and the team would have to provide security. They could see on the screens that people were out moving and potentially shooting at them, and they're trying to diagnose and treat, their shipmate. They're loading them onto a stretcher and transitioning the stretcher down the hall to an aircraft. Loading onto aircraft, then it's a simulation of an aircraft taking off and flying to the base. It lands at the base. They take the stretcher out of the aircraft, pack it back down the hall to the other section, and then it's a representation of an operating suite or a hospital room where they could go on and provide more advanced care. Just very impressive to see. It's such a large space. I had never seen anything like it, and I'm not aware of anything else like it. All right, we're going to anchor here and talk for a moment about the center and their hybrid approach. Up until this point, I really do not feel that I have done a good job conveying to you exactly what I've seen, although I have broke down all the individual parts and pieces. What makes the center so spectacular is when you put it all together in this hybrid approach. Again, simulation is provided to accomplish the learning objectives for the instruction. And in order to do that, for example, there was a central room, and off of this central room, there were these 12 other rooms. And each of the rooms had a camera that had 3 different views. There was a person or two people that sat outside at a control panel, and they could see all of the rooms, all of the displays, and they could change the camera views in order to get the best view for the situation as people moved around the room. They decided to do this with this one central person controlling the cameras because when they let the people that were observing, for example, through the computer monitors control the cameras, they were simply wearing out the cameras much too quickly because they were rotating them to too large a degree. Now, for example, you have a medical student and they come in and they're going to have an assessment. Now, they will bring in the faculty. The center will bring in the faculty and they will explain, this is what you're going to be observing. This is a simulation. And they'll have them practice rating some vignettes so that everybody has kind of a consensus of what's going to be rated. And, all of the standardized patients are trained for the individual scenarios that they're going to be displayed. So you walk in from the hall, then you go to your assigned room. And in the room, for example, one scenario is there's an adult standardized patient who again is like an actor or role player who is there. And the job of the learner is to take an oral history, find out what is going on with that person, and come up with a diagnosis, and after they've done a physical exam. When their time is up, and it's announced over loudspeakers when your time is up, the instructor will come in and the student will have a little time to get everything together. Then they will give a presentation and say, this is the person that I've seen. They presented with these symptoms. We have these dual diagnosis. I've eliminated based on these criteria, and I think that this is really what we're after, and here's my treatment plan. And the instructor can give them feedback on how they did for the presentation. The standardized patient can also give them feedback on how they, conducted the physical exam. Again, standardized patients are like highly trained subject matter experts. So they can say, hey, you were touching me here, and really it should have been under my shirt, not over my shirt, or the positioning was off. And they can really provide them some good examples. Now, the instructor could have been in the room. They could have been outside the room with a headset that was jacked into the wall so that they could watch through a one-way mirror, and they can hear what's going on through their headset. Or they could be sitting at a central terminal bank of computers, a bunch of laptops, and they could be watching that room on that terminal. And if they were watching multiple rooms, they can switch and they can watch any of the 12 different rooms. When that scenario is over, the student, the learner, rotates to another room. For example, when you enter that room, there was an adult and a child. These, again, were standardized patients representing a parent with their child. And the learner had to do an oral history for the child, working with the parent, talking with the child about what's going on with them. They had to go through all their diagnostic criteria, as I crudely previously described. Their time is up. They make a presentation to the instructor, and they get feedback, from the instructors and even from the standardized patients. They could rotate to another room. A third scenario I saw, there was a parent in the room. There was a nurse in the room. These are both standardized patients. And on the bed, there was a high-fidelity child mannequin. So the goal of the exercise from the student's perspective is they come in and, okay, they've got to do the oral history, the physical exam, make their diagnosis, and come up with their treatment plan. And again, the vital signs of the high-fidelity mannequin can change up and down, get better, can get worse, depending on the situation. Responses can be provided from the mannequin based on inputs from the instructor outside the room, again, watching through the one-way mirror. And but that's not all of it, because really the exercise is to see, hey, how does this student, the learner, do with diagnosing this child? But what's the interaction like with the nurse? Are they using the nurse effectively? Are they getting the nurse to help with tasks so that they can get more accomplished? Are they treating the nurse in an appropriate manner? How do they interact with the parent? Now, the parent that I saw was just incredible, because as the child's vital signs quickly got worse, the parent became very upset. They were nervous. They were just on the verge of tears. And you would think their kid was just about to die. I mean, it was just an incredible performance. And you thought, oh my gosh, this is really intense. And that's what their role is, to treat that mannequin like it's a real child, to kind of help suspend disbelief. Again, structure, debrief, rotate rooms. And, for this room, you come into the part task trainers for the leg, where you have to insert the needle into the bone, for example, to administer fluids. They would go over to a child mannequin that was had some simulation, some digital aspects, and they used the breathing bag to do manual compressions for oxygen, and then they could see on a tablet how the child was doing. Or they looked in the simulation of the ear, which is just an ear sitting on the table, and they look in with their instrument, and they were able to see the structures that are there and projections from a computer. And so they can diagnose, hey, what's going on with this ear? Is this a healthy ear, or are there questions? And then the student can ask the instructor, look, this is why I thought there was a problem with the ear. I'm looking right here. And the instructor can say, oh, no, that's really not a problem. That's a normal, healthy ear. But it's just really such a good experience. It's such a well put together event. Again, you're there. It's very believable with all the standardized patients. Everybody's trying to do their best, and it's just an incredible experience. I observed some students doing a phone interview with a parent. Something was wrong with their child. They were concerned. They called in to speak to a doctor. They got the learner on the phone. The learner has to do an oral intake over the phone, figure out what the symptoms are, make a diagnosis, come up with a treatment plan. If the student starts to get exasperated and frustrated and stressed out, the standardized patient, the actor, feeds off of that anxiety, and they become more anxious. They become more nervous and more frantic as they're talking about their child. So if the student doesn't keep the dynamic for their anxiety under control, it can escalate very quickly, and they've got a very, very stressful situation on their hands. A very interesting note that goes into the detail that the center provides deals with sexual assault interviews. They prohibit any of their standardized patients who have experienced a sexual assault from role-playing that aspect of being a person who's experienced sexual assault with a student. So they screen the standardized patients before these sexual assault interviews to make sure that is not in their history. But they actually bring in therapy dogs when they're doing these sexual assault interviews, just in case this brings up traumatic memories for the student. Perhaps they have experienced sexual assault in their lives, or they've had a close friend or loved one who has experienced a sexual assault. So they will bring in these therapy dogs just in case these interviews trigger some very intense emotions in the students, which I thought was just an incredible detail and foresight on the part of the center. There is potentially a gold mine of data available at this center, because again, they do video recordings of all of these sessions with the students, and they keep the recordings on file, there on their servers at the center. So if anyone is interested in doing research on anything that I've described up to this point, I would encourage you to contact Dr. Lapriado and I'll provide his contact information at the end of the slides, because he seemed very interested in people using this data. He would love to engage you and see if you could come to some kind of understanding about what you're doing. It's a data-rich environment. There is a camera in every room, and that camera is never shut off. So as long as the simulation is going, that camera is recording data. So you could potentially come in and you could look at the data for one student and see how they're doing. You can come in and you can assess the performance of the standardized patient. And once this starts, everyone forgets there's a camera in the room. The instructor is being recorded as they're debriefing their students. So you could come in and you could evaluate the instructor's performance for a number of different categories. So again, if any of this sounds interesting, I encourage you to talk to Dr. Lapriato. The first thing I thought is, could people at the Naval Postgraduate School do some kind of master's thesis, on this work? Because again, there is I'd say a plethora of data. As much as the center has going for it, Director has ideas for what they would like to do in the future. They would love to bring in a dedicated program manager to manage their research portfolio. They'd like to bring in a research director just to help structure things better. Dr. Lapriato has ideas for trying to get an additional qualification designator for people that can meet the criteria that's set forth. They would like to do enlisted training in order to help our enlisted personnel become better at working in simulation centers. Otherwise, they're largely learning this from on-the-job training, OJT. They would like to move the certificate program to a master's degree. So they'd like to flesh out the certificate program and really like to have a full-fledged master's experience. Now, some ideas that I have that the Director did not mention, I could really see them benefiting from a military deputy working there. If they could have an O5 come in and help run the facility, I think that would be a fantastic experience for a commander or lieutenant colonel. And they have all of this data, and you can see all of the rooms on the displays. So I wondered, could people at a remote site, could they watch this video from a distance? Again, I'm not sure of all the technical issues or if it's even possible, but I thought that was just a very interesting thought of something that they might be able to do in the future. I'd like to thank Dr. Lapriato for the kind invitation to come out his center on 2 different occasions for my practicum. He sat down and took time to participate in my structured interview and answer a lot of questions about his center and how he ran things and their best practices. He took me around, showed me all of the nuances and all the details, really the behind the scenes that allowed me to put this presentation together. And again, he's just a great individual. I really appreciate his help and his mentorship as I went through my practicum, and just very passionate about the work that he does, and he has a great thing going. I mean, he's created something very special as a director. And again, I very much appreciate his assistance. Thank you for taking the time to listen to this presentation. I hope you found it informative. Again, we've talked about a state-of-the-art medical simulation facility, and I've talked about the Val G. Hemming Simulation Center. Again, if you have any questions, I'd appreciate it if you'd contact Dr. Lapriato and address them with him. I just think the world of the work that he's doing. I was incredibly impressed. Dr. Darkin asked me about my ideal simulation center, and what they've created there is really, far exceeded anything that I thought was possible. So again, I really appreciate the opportunity to visit and do my practicum. Have a good day.